heart rate. Increase heart rate. Tachyarrhythmia. As a PA, what might you think one of the most nerve-wracking things a patient could come in and say to you? If they start a sentence with, so I read on or Google, or insert that's you're just like, oh God, here it goes, right? Here it goes. You never know what your students they come up with, of what they've read and what they believe to be true actually. Right, so tachyarrhythmias, we'll talk about that today, and the next week we'll go over some breathing. Here's the deal when we think about these tachyarrhythmias. Does this mean that everybody that has atrial fibrillation, because we kind of talked about atrial fibrillation, that everybody that has atrial fibrillation is always tachycardic? No, that does not mean that. But when we think, we look at that bottom rhythm strip, and we see a fast heart rate, these are your differential diagnoses, and you need to think about these in your differential. So that's an overarching, I see a fast rate, these are all my differentials and my fast rates. And then we can start narrowing them down depending on what the QRS looks like. We got our ELOs, our TLOs. Let's do a little bit of a review. Osinaga. Let's see, Osinaga. Okay, ma'am. So 6-second and 10-second method for identifying the rate. What do we use that for, or what must we use that for? You can use it for anything, but what must we use it for? Irregular, that's right. So irregular, if you're looking at your rhythm, and your rhythm is irregular, we need to use that, because counting method will depend on R to R. And R to R is going to vary. So very good. What about this? Boswell, Gardner-Boswell. Okay, ma'am, what do you think the rate is on this? E, pretty fast, huh? So again, we talked about counting method, we talked about 6-second method, 10-second method. So you certainly could use a 6-second method here, right? We gotta count all of those hours. So how did you do it? The counting method, right? So the counting method. And when you have so many R waves, it's like, I'm telling you, y'all are gonna have to practice a little bit better. By the time you get to senior, and we're doing women's health, I'm gonna need y'all to be able to catch a little bit better. All right, so if we took our time and counted all of these R waves, oh my gosh, okay, right? Like the patient's halfway dead by the time we get through all these R waves. So especially when you look at this, we've got an obvious regular rhythm. Let's just do our counting method. Really quick. Oh, we got one right here. 300. Wow, that was easy. Half a second, right? As long as you remember your number. So it's probably just below 300, but it's pretty darn fast. Now, if you count all of these R waves, you're going to have about 25 R waves. So again, I said 300. It goes just behind that line. So we got 300 and 150. So we know it's not 150. It's way closer to 300. So it's probably around 250 to 260 by looking at here. And if we count the R waves, we have 25 R waves. We're taking 25 and we're timesing it by 10, because it's a 6-second strip, and 6 times 10 is 60. So that'll be about 250. 250 All right, very good. We are going to continue on with our deliberate approach to reading these ECGs. We're going to start at that bottom rhythm strip. I'm going to count and look and see what the rate is. And we can do that by 10 seconds, 6 seconds, or the counting method, depending on if the rate is, or the rhythm is regular or irregular. Once we identify the rate, the next thing we're going to look at the rhythm. Remember, when we're looking at the rhythm, it's not just I'm looking at R to R to tell me if this is regular or irregular. A whole bunch of components are involved in looking at this rhythm. So yes, I want to identify, is this regular, is this irregular? That's one of the first things I want to do after I do the rate. But then I've got to look at those QRS complexes. Are they wide? Are they narrow? Do I have QRS complexes that follow after each P? Okay, what do they look like? Are they grouped? Or are they separate? And what ST segments. ST segments, I'm taking my eyesight from that bottom rhythm strip, and now I'm looking up into the main portion of the ECG, and I'm putting likes with likes. 1, AVL, V5, V6, 2, 3, AVF, V1, V2 for septal, V3, V4 for anterior. And that way I can say, do I have in this section of the heart evidence of ST segment elevation, ST or ST segment depression? Do I have any changes in my ST segment? I've got to look to make sure those P waves are there. If they're not there, something's going on with the atria. If they are there, do they look the same? Because if it's coming from the same foci in the atria, they should look very similar from beat to beat to beat to beat. And do I have a P wave before every QRS? What about my T waves? Are they asymmetric like we would expect? Or are they flat or inverted or peaked? We've got to look at those. And that will tell you if there's something going on, probably with the electrolytes. If the T wave is more commonly abnormal, associated with electrolyte abnormalities or ischemia. We've got to look at those PR intervals. If I have PR intervals, they should be consistent from beat to beat to beat. If instead I'm looking at that PR interval, it's getting longer and longer and longer and longer, there's a problem at the AV node. There's something that's blocking that direct depolarization down to the ventricle. And you look at that QT interval as well. Is it too long? Is it too short? Or is it within that normal window? 360 to 460 per minute, 350 to 450 per minute. So all of that goes into when I'm looking at the initial portion of the rhythm. Now, let's say I go down the bottom of that strip and I'm like, this is a tachycardic rate. Now we're looking at these differentials. Tachycardic rate, is it sinus tach? Is it SVT? Is it AFib? Is it A-flutter? Is it multifocal atrial tachycardia? So once I identify I've got a tachycardic rate, now I've got to figure out, are my QRS complexes wide or are they narrow? And by wide, I mean greater than 3 boxes or 0.12 seconds, or 120 milliseconds. So wide or narrow? So I've got my tachycardia, okay, here's my differentials, but now, is it wide or is it narrow? Because that will then hone down my differentials even more. So narrow and regular, okay, narrow and regular, sinus tach, SVT, A-flutter. I'm looking down here, I've got my sinus, I've got my tachycardia. Is it narrow or is it wide? If it's narrow, is it regular or irregular? If it's irregular, then you have to go down to the next. Narrow and irregular, atrial fib. We've got A-flutter with a variable block, multifocal atrial tachycardia. So when I give you a question on the exam, it's going to say, either you're going to look there and it's going to be obviously regular or obviously irregular. It's going to be obviously wide or obviously narrow. If you have a narrow complex, regular tachycardia, and you choose atrial fibrillation, it's going to be right? No, it's going to be wrong because that's irregular. So as you're studying, put your likes with your likes. These are my narrow and regulars. These are my narrow and irregulars. So immediately, you can start knocking some of those answers off on the very beginning. So narrow and regular, again, sinus tach, SVT, A-flutter. Narrow and irregular is going to be AFib, A-flutter with a variable block, which we'll talk about, and then multifocal atrial tachycardia. I look down there, and I've got a tachycardic rate, but my QRS complex is greater than those 3 boxes or equal to or greater than those 3 boxes. Means wide. Now, is it regular or irregular? Wide and regular, V-tach, V-flutter. Wide and irregular, we have V-fib. We have something called polymorphic V-tach, where it's still a form of V-tach, super fast form. Or we also have something called torsade, torsade deployment. You gotta differentiate between fast and slow, narrow and wide, regular, irregular. Let's talk about our narrow and regulars. First thing, we got our sinus tachycardia. We have something called SVT, supraventricular tachycardia. And that means tachycardia above the ventricles, but we talk about 2 specific forms of SVT. We've got AV-NRT, for AV nodal re-entry tachycardia, and then we have AVRT or AV re-entry tachycardia. The only difference is that word nodal. So one is a problem at the AV node and the other one is not. And then we have atrial flutter with a non-variable block. And what that means is the atria are fluttering and the AV node is allowing the depolarization down to the ventricles at the same time every time. Okay, so it's regular. It's non-variable block. Patients that have tachycardia typically present about the same way. They come in, maybe weakness, dizziness, palpitations. I feel like my heart rate is being really fast. I feel like I was going to pass out, or I actually did pass out. And sometimes they even have shortness of breath that's associated with because of the rate of what their heart rate is. It's so fast sometimes. So sinus tachycardia, how do we know, or how was a good teaching tool for us to remember if this is a sinus tachycardia? Lead 2, what's the P wave going to look like? Upright. Lead AVR, what's the P wave going to look like? Down going. So, someone comes in, I look at that bottom, I got a tachycardic rate, I'm like, okay, yes, okay, I know. Now I got to figure out, is it wide or narrow? What does it look like? Wide or narrow? Narrow, okay. Well, now I got to think of my differentials for my narrow complex tachycardia. And for this, we clearly see P waves. So we have a PQRST, PQRST, so we clearly see P waves. We're going to go up to our lead 2. Is our P upright? Yep. Is our AVR, is our P down going? It's right here, down going. So we're like, oh, okay, and it's regular. We got that regular R to R. If it marches out, those march out like a metronome in rhythm. Okay? So this is a sinus tachycardia. Clearly see the P's. We got a narrow complex, and it's regular. And these patients oftentimes will come in with reasons for sinus tachycardia. Maybe they have a fever, so check that. They might be volume depleted, so dehydrated. And they went running long run, it's hot outside, and their heart rate was increased. We also think about it specifically associated with exercise. You go out and run a couple of miles and you check your heart rate's probably going to be high, at least for the interim, right? Then it'll slowly slow down. So we want to make sure when these patients come in and we have a document, and that gives you the paper and says heart rate's 108, you can't just assume that it's a sinus tachycardia because they look like you. If they look like me, you would totally not assume they were like, oh, she's old. Right? There must be something bad going on, right? But young, healthy people have bad things too. So you have to, anytime you have a tachycardic rate or a bradycardic rate, you need to get an EKG to make sure there's no underlying etiology that's causing that. So these patients, especially for females, you might think about, are they anemic? Is that the cause? Maybe that's what's causing them to be weak and lightheaded. A common cause is tachycardia is thyroid problems. So sometimes if you can't identify any other reason for persistently tachycardia, it might be a thyroid problem. But in order for you to assess and identify sinus tachycardia, you're going to look at that bottom rhythm strip. You're going to figure out if it's fast or slow. So this is fast. Narrow or wide, it's narrow. Okay, so I've got a narrow complex tachycardia that is regular. And then you're going to go through those different SVT, sinus tachycardia, and A flutter with a non-variable. So far we're going to talk about sinus tach. But what does SVT look like? Well, SVT, again, we have 2 forms of SVT. And really, we just call them SVT. We don't usually call them specifically AVNRT or AVRT. We just call it SVT. AVNRT is a problem at the AV node. This is going to be the most common form of SVT, and it's usually seen in younger people. So children, adolescents, young adults is typically when this is seen. Certainly can be seen in older folks as well, but I'm just telling you most commonly in younger folks. And we think about this kind of in association with maybe increased sympathetic tone. So someone that's drinking a lot of caffeine, someone that's using drugs, someone that's not getting much sleep, someone that has a lot of anxiety, anything that increases sympathetic tone. And the pathophysiology behind this is we are still starting at the SA node. We've got a depolarization that's going from the SA node, it's going out to the myocardiocytes, the right atrium is being depolarized, left atrium is being depolarized, it's coming down to the AV node. The problem is at the AV node. And at the AV node, for some reason, these patients that have AV and RT have two pathways at the AV node. So they have maybe some scarring that has occurred, some fibrosis, something is occurring at the AV node. So as this depolarization is occurring, SA node down to the AV node, we're getting some of those depolarizations that are going normally down to the ventricles. Okay? So that's great. But the problem is that we get a re-entry of their circuit. So you get some depolarization go down, but some of those will come back around and directly back down the AV node. And then they'll come around the AV node and then back down through to the ventricle. So we have a super quick turnaround of depolarization. So instead of the heart rate depolarizing 60 to 100 times, now we've got this depolarization because we have this recurrent depolarization really quickly. Now we're talking about rates in the 200s, 150 to 200, and sometimes even a little higher than 200, because we're not having that normal repolarization. Some cells are repolarizing normally, but the majority are coming back down in this circle, this like circle of death that's coming around the AV node and then going right back down to the ventricle. So luckily the AV node is able to block some of these, but a lot of them still get through, which is causing the high heart rate. This is what your ECG might look like. So again, we're looking at that bottom. The heart rate here about 144 or so. If you were to count all your R waves at 24 times 6, 144. All right, so we've got a high heart rate. We've got a narrow complex. Does it look regular? Looks pretty regular, right? If you take your piece of paper out and go from R to R, it looks pretty regular. But what do you not see on here that we saw in the sinus tachycardia? P waves. Where are they? Are they there? They're probably hidden because our rate is so fast. When we think about sinus tachycardia, right? Now, we are having a really bad cold and flu season, right? It is not uncommon for me to see a person come in that has a flu with a heart rate of 150. Not uncommon. Okay, but typically, for sinus tachycardia, we are looking at less than 150, for adults. Kids can be higher, but less than 150 for adults. These guys are running anywhere upwards of 150 to 200. I do not want you guys to memorize these rates, because the rate is going to vary from person to person. Okay, so I just said 150 to 250. You guys are like, oh, but this is 144. Yes, I understand that. The rates are giving you estimates of about what we should look for. Okay, but we have this, you have a tachycardic rate. It's narrow, it's regular. We've got to go through our differential. All right, if it's sinus tac, I should be able to see P waves. I'm going to look at lead 2. I don't see a P wave in lead 2. I'm going to look at AVR. I don't see it. So we know that it's not coming from the sinus node. It's coming from up there, but we don't see it clearly here for us to tell us that this is a sinus tachycardia. This is an SVT. It's coming from somewhere above the ventricle. Now, AVRT is still a supraventricular tachycardia. A rate is still about the same, 150 to 250 or so. Still typically affects young folks. But the problem with AVRT, we have that re-entry, but the re-entry is direct communication between the atria and the ventricles. Direct communication. We have what we call an accessory pathway. Have y'all heard of Wolff-Parkinson-White? You ever heard of something called lone ganglion-Levine? Probably not that so much, right? But something is called a hole, a pathway in between the atria and the ventricles. Well, it's probably not that big of a deal if your heart rate's 60, it's just going down to the ventricles. But it's a huge deal if your heart rate's 250. Because now The AV node, some of those depolarizations are going through the AV node and being blocked, but a lot of those depolarizations are like a super highway going directly down to the ventricles. Can the ventricles sustain a heart rate of 250? Not for very long. Not for very long. Right? So we're coming up somewhere up here in the right atrium, we've got depolarization that's occurring, going down to the AV nodes. Some of those are going down to the ventricles normally. But again, others are coming and they're going down through here. Now, we have something called the most common type of AVRT is orthodromic. Orthodromic. Orthodromic means this. Your depolarization came from the atria, came down to the AV node, towards the ventricles. Some depolarization went right down to the ventricles. Otherwise, that depolarization went right back up through the superhighway and back down to the AV node. Up through the superhighway and back down. So again, we don't get that full repolarization. We get those much faster depolarizations, and so that leads to a much faster heart rate. So how do you differentiate this between sinus tach? P waves. P waves. We do have something called antidromic. Antidromic is very dangerous because antidromic doesn't hit the AV node very much at all. It's going directly down through. Well, here we do have some block of that depolarization through the AV node, but it's coming back up around and hitting the AV node pretty quickly with that. Here is an example of an orthodromic, meaning it's going the right way, but it's just coming back up through that accessory pathway, that superhighway. Here's an example of an ECG. So this is pretty fast. Okay, we have 37 R waves across here, 37 times 6 because this is a 10-second strip. How do we know it's a 10-second strip? 12-lead ECG. Okay, so we're about in the 200s here. It's about 220 or so for this heart rate, so pretty quick. What do we not see here? P waves. The P waves are probably there, but we're so fast that we can't get a good view of the P waves. There are sometimes it's kind of obvious that they're pushed into these QRS complexes. But the bottom line is we don't see any obvious P waves, and the rate is pretty darn fast. Okay, 150, 250 or so is our rate. So many of you are like, okay, look, if I go back and I look at this, besides the rate, can I tell the difference between that and this? AVNRT versus AVRT. Guess what, folks? It doesn't matter. It doesn't matter. They are both forms of SVT. You will not have to decide on test what the difference is because there's no difference in treatment. There's no difference in treatment. The treatment's going to begin the same. Okay? We don't have antidromic up here because we don't see antidromic very often. I don't want you to focus on that. Antidromic presents differently on your ECG. But the bottom line is between AVRT, AVNRT, the treatment according to the ACLS algorithm is going to be the same. Okay? It's an SVT, and we treat it as if it's an SVT. But you do need to know the difference between this SVT and sinus tachycardia. P waves. Yes, ma'am. So think about how a T wave presents. Okay? P wave, we should have still that rounded. When we look at these, do you see they kind of come up and then we have that quick down, that asymmetric? That's kind of your indication. Sometimes it is very hard. Sometimes it is very hard to determine. A big part of this is how is that patient presenting? Sudden onset, because usually SVT is a sudden, I was fine, and all of a sudden my heart rate's going like 200. So we have that sudden onset, little diaphoretic, they're young, they're otherwise fairly healthy. So that history is going to give you that other indication. Okay? But for these are a little bit more associated or appearance-wise with T waves because of that asymmetry. All right, another narrow complex tachycardic rate that we need to know is atrial flutter. So atrial flutter, when we look at the atrial rate of atrial flutter, okay, we're upwards of the mid 300s, so 250 to 350. So really fast atrial rate. The ventricular rate is going to vary. Now, how do I know? So on examination, I'm feeling someone's pulse. Am I feeling the atrial rate or the ventricular rate? The ventricular rate. So your medics are going to give you a piece of paper, and that piece of paper, and this person comes in, I've been lightheaded, dizzy, weak, and you're like, you're fine, your heart rate's 80. It's just a number. You don't know anything about that heart rate except for the rate. What is the rhythm that's associated with that? Because someone with atrial flutter can have a ventricular rate in the 70s or 80s or 90s, but what is their atrial rate? What are the atria doing? So atrial flutter means that there is a single foci outside of the SA node, a single foci in the atria that is just sending off a ton of depolarization, a ton of electrical activity. The AV node, by virtue of it being the AV node, is like, whoa, we can't do all that. We cannot let all that stuff through here. So it's going to allow some of those depolarizations that are strong enough to get through, they're going to allow those depolarizations through. And if this is atrial flutter with a non-variable block, as I mentioned a little bit earlier, it means that the AV node is letting every third beat through, every fourth beat through, every second beat through, routinely. Routinely, that's what's happening by virtue of how that AV node is doing. The most common form of A flutter is what we call 2-to-1 A flutter. This is a pants board question. Someone comes in, they've got a consistent heart rate of 150 with palpitations and dizziness. That is 2-to-1 A flutter every day of the week. Every day of the week, and that's what you'll answer on the PANS test. I just retook my test, the PAN rate. They asked me that same question, and they asked me it 30 plus years ago too. So it's going to be there, and it's going to be A flutter, and it's 2-to-1 A flutter. 2-to-1 A flutter. The problem is when you see 2-to-1 A flutter on an EKG, you're not going to be able to figure it out. You're going to be like, I have no idea what this is, because it's R wave, a little ditzel, R wave, a ditzel, R wave, a ditzel. So it looks like an R and a T, an R and a T, an R and a T, but that's actually a flutter wave. Okay? So these patients typically have some sort of underlying cardiac disease. Heart failure, they've had an MI, they recently had ischemia, some sort of underlying cardiac disease that's causing it. The ultimate issue with these patients is because our ventricular rate seems to be okay, our ventricles are doing okay, we're getting probably a decent amount of blood supply to the body, heart, lungs, and throughout, but the issue is that foci is beating so quick, or sending out those electrical conductions so fast, the atria are not really very effective in pushing that blood down to the ventricles. And that blood will kind of hang out in the atria and then start to coagulate. And if you get clotted blood that ultimately gets through that AV node down to the ventricles and out to the blood, what's it going to cause? Stroke, pulmonary embolism, but usually stroke with these patients. Okay? Because we don't have good movement of blood in the atria because it's hanging out, because we don't have really good contraction of the atria.
Ma'am, so when the AV node lets a signal through, so in the case of the rhythm circuits up here, right, so we've got two atrial depolarizations before the one thorax complex.
Mm-hmm.
Great, is that just like a summation of charge essentially? So it's like, we have a foci in the atrium that is on fritz, and it's pulsing.
Right.
In addition to the SA nodes,
Yep.
like a summative charge until there's sufficient charge by the AV node to let it fully.
Right. It's usually the SA node, I mean, it might be firing intermittently, and it's what you said though, it's kind of a sum. I say it's the AV node letting things through, but it's really the fact that eventually you get a strong enough electrical charge that you can push through the AV node. But otherwise, most of these flutter waves are not strong enough to make it to the AV node and then through the AV node. But occasionally, you will get that strong charge. It gets to the AV node, and then the AV node's going to let it go down into the ventricle, right? But otherwise, you're getting this. It's like a little chatter, and then boom, oh, finally get one down. But otherwise, the foci and the electrical conduction is not strong enough to get all the way down to the AV node and down through the ventricle. But you bring up a good point here. If we look at this, okay, I want you to keep that in mind because I'm going to come back to that in just a minute. This is an example of atrial flutter with a non-variable block. Meaning every third or every fourth depolarization gets through routinely. For this, when we're looking for atrial flutter, we think of this as a sawtooth pattern. And we think of it as sawtooth pattern. And the best leads to see atrial flutter is V1, lead 2, 3, and AVF. And lead 2, 3, and AVF are looking at what part of the heart? Inferior part of the heart. So it's V1, V2, 3, and AVF. So let's look at that. Let's look at V1. When you look at V1, do you guys kind of see what it kind of looks like? You would come U. That's a flutter wave. Looks like waves. Okay, it looks like waves. If we go down here to 2, 3, and AVF, what you can tell in between here is the fact that you don't know, is this a T wave, is this a P wave? There's nothing clear on whether it's a T wave, whether it's a P wave. That's your first indication, like, why don't I see something that makes sense to me? Right now when I'm looking between this R wave, I can see an R wave, I can see an R wave, I can see it here. R waves in lead 3 are typically upright, but I can still see an R wave. Does everybody agree with that? You can see an R wave? But what you can see in between those R waves is stuff. I just see things in between there, but nothing that makes a lot of sense. That is your first indication that something is not right, right? But then when we look at our V1, we can see what looks kind of like inverted or like U waves, like what we call them flutter waves. And we know that this is a 3-to-1 flutter because we can count. You've got a point here, a point here, and a point here. That's 3 flutter waves. That's the P waves, okay? But they're not strong enough to then be conducted down to the AV node, down to the ventricles. They're just the atria are just doing this, okay? They're fluttering and they're causing these P waves to look as this. So these are actually P waves, and that is how you get your atrial rate of 350 to 450. Yes, sir. Okay, now ask me that again.
But I'm not sure if that's a J point, but the first P coming off the R wave, why did it come down? Like the slightly to the left.
This. So the way that these are counted, and the way that these are counted is this is the end of your R wave. This is your end of your R wave. So this is your P wave, this is your P wave, this is your P wave. This is just the end of your R wave. Do you guys see that? You see what he's asking? So he's asking about where do we start this counting at? Okay, this is the end of your R wave. Okay, that's your R wave coming up. So this is your P wave. You have a P wave here, you have a P wave here. Then it's going into the next one. Those are all P waves or flutter waves. And that is your sawtooth pattern that you're going to see with atrial flutter. Yep. Look at your R waves at the bottom. Are those regular? Do we have regular space between those R waves? Yeah, they look pretty regular. And that's how you know we have narrow complex. Your ventricular rate is not fast though. Could it be fast? It can be fast, but it can also be within normal parameters, depending on if this is a 2-to-1. So if it's a 2-to-1 A flutter with a normal conduction every other beat, well, your heart rate's going to be 150. You're going to have a tachycardic rate. If this is a 3-to-1, you're not. If it's a 4-to-1, you're really not. If it's a 5-to-1, you're really not. Matter of fact, you're going to have a heart rate that's almost bradycardic. But it's the atrial rate on why the powers that be, which is not me, but why books like Dubin's and Garcia put this into the atrial tachycardic rates is because a good point, we were looking at the atrial rate that we're talking about. So if we come back to this then, we've got these flutaways, 1, 2, 3 flutaways, 1, 2, 3. Do we have any, do you guys see the difference between this R to R and this R to R? This is, what do you think we would call this? Yes, but a variable rate. This is 3 to 1 non-variable. So when you look at the R's appear to march out like they're regular rate. If you have variable, 2 flutters and then a QRS complex, 3 flutters in a QRS complex, 1 flutter in a QRS, that's going to be a variable rate. It's still atrial flutter, but when you look at that, those R waves are going to be variable. So for atrial flutter with a non-variable rate, R's to R's are going to be regular, and our atrial rate is elevated, and sometimes our ventriculated as well, depending on how many flutter waves are finally getting through down to ventricles. This is an example of atrial flutter. Is this a variable rate or a non-variable rate? Non-variable. We know because if we took our piece of paper and we put it on this R wave and this R wave, and then we moved it to the next set of R waves, next R wave, next R, we don't have to move the paper. There's no change in where those 2 lines fall. They're going to fall from R wave to R wave. So it's a non-variable. And how many flutaways? 1, 2, 3. So it's a 3 to 1 conductivity. I'm not going to ask you to tell me how many flutaways are there. I'm not going to say count the flutaways, because some of you are looking at me like I cannot count them. You don't need to count them. You do have to understand variable and non-variable, and you're going to be able to pick that out because you're going to look from R to R. And you're going to say, I've got a narrow complex, and it looks like I'm going to look at V1, and I'm going to look at 2, 3, and AVF, and if I don't see clear-cut P waves, T waves, in a person that has cardiac disease, hypertension, CHF, hyperlipidemia, okay, this is going to be atrial flutter that is non-variable. All right, so that is our tachycardic and regular. Narrow, regular, tachycardic. Sinus tach. What's our other one? SVT. And then atrial flutter with a non-variable block. That's only 3. That's only 3 things you got to remember for that. Okay, we don't need to think. So if you're looking at the bottom of that script, you got a question on it, and you're like, this is fast, it is narrow, and it is regular. All right, I got those 3, and then I'm going to look at my answer. I'm going to get it, I'm going to look at my answer, make sure that I've got it in. All right, if it's narrow and you're looking at the R to R, it's irregular. So the rate is fast, but we have an irregular R to R, atrial fibrillation, multifocal atrial tachycardia, and a flutter with a variable block. Those are 3 things that we want to focus on. So atrial fibrillation. Atrial fibrillation, we've got those high atrial rates, but the ventricular rate is going to vary from person to person. Especially if they have a history of atrial flutter and they're on medication to control their ventricular rate oftentimes are in the 60s and 70s. But usually when these patients are first diagnosed with atrial fibrillation, they're going to have a fairly fast heart rate. Ventricular rate, in addition to that super fast atrial rate. Again, think about people that have underlying cardiac disease. Underlying cardiac disease, hypertension, hyperlipidemia, CHF, that kind of stuff. The other thing I want you to put in here is young, healthy people that have thyroid disease, like hyperthyroid. If they're coming in their initial presentation is atrial fibrillation, you need to check a TSH because it's probably hyperthyroid. Because most young people don't get atrial fibrillation. Most young people do not have atrial fibrillation, but they will if they're hyperthyroid. depending on how fast their ventricular rate is, will depend on the degree of their symptom. So if they have a heart rate, 140, they're probably gonna be a lot more symptomatic if they have a heart rate of 100, they have 110. But usually those palpitations, weakness, dizziness, a lot of times patients will remember, like, I immediately felt that my heart rate was high, and now we have to determine, okay, something that's sudden onset. We already talked about SVT being sudden onset. Atrial fibrillation can be sudden onset as well. When we think about the real complications associated with atrial fibrillation, it's just like we talked about atrial flutter, increased risk of stroke. Because now what's happening is we've got atrial flutter is one foci in the atria that's firing. Atrial fibrillation is a whole bunch of foci in the atria that are firing. Most of the time, it's ineffective fire. We don't get enough electrical activity for conduction to the AV node and down to the ventricles. Okay? And so most of the time, we're going to see what we call fibrillatory waves. It's going to look like a whole bunch of just squiggly marks in between very clear QRS complexes. So squiggly in between QRS complexes. And it's going to be irregular R to R transmission. So this top one is an example of all these different foci in the atria. Each one of these little things up and down is from different foci. It's P waves, but they can't come to true fruition because there's not enough electrical activity associated with them. So all we can see is this on our ECG. And we're looking at our R to R. Our R to R is irregular, and this is that classic irregularly irregular. But we also notice that our R waves are narrow. So our QRS complexes are narrow, or irregular. You don't really see any clear P waves. Will you occasionally, if you really study these, will you find something and say, well, that definitely looks like a P wave? Absolutely. Absolutely. The atria are firing. They're just not firing very effectively. Okay? And they're not firing effectively consistently, which is why we have this irregular rate. For atrial fibrillation, I want you to look at V1. I want you to look at leads 2, 3, and AVF. Those are going to be the most common leads that you're going to see abnormalities in. If we looked at this and we looked at lead 1, is there anything exciting about lead 1? Lead 1 just looks like I have R waves. I don't really see anything in between the R waves. Okay, so if you look just at lead 1, you would be like, I mean, I see a T wave, I see an R wave, I just don't see a P wave, right? Does everybody agree with that? But look over to V1. Look over to V1. And in V1, do you see a whole bunch of kind of up and down in between those R waves? That's why we use V1, V2, V3, and AVF to really help us hone in on this atrial fibrillation. Is this, like, what is this? We know that it's not atrial flutter with a non-variable block because we've already identified this as an irregular. But it could be atrial flutter with a variable block. It could be, but we don't really see good flutter waves. We just see a whole bunch of a little bit up and down, like squiggly marks up and down above the baseline. We look down here, we can see the same thing. We can see a T wave here, we can see a T wave here, a T wave. We don't see any clear P waves. We have irregularity from beat to beat to beat. And when you're feeling that person's pulse, you're going to feel that irregularity every single beat that comes out. Every single beat, you're going to feel that on their pulse. So that is atrial fibrillation, where we don't really see flutter waves, we don't see good P waves, but we see a whole bunch of squiggly marks in between our R complex. This is another version of atrial fibrillation. We have that irregularity between our R waves. This shows you this R wave to this R wave is different than this R wave to this, and different from this R wave to this. So a whole bunch of irregularity that we see. We see up here in V1, you see in between our R wave here, maybe a T wave here, we don't see a clear P, but we also don't see those flutter waves that look like the U waves that we should see if this is atrial flutter. This is atrial fibrillation as well, especially in a person in the setting of underlying cardiac disease or thyroid problems. Another narrow complex irregular tachycardia is something called multifocal atrial tachycardia. So if I say multifocal atrial tachycardia, where is the depolarization coming from the atria? Places, different places. Like not the SA, no, but different foci in the atria, just like we saw with atrial fibrillation. Only here we actually do see P waves. But because the depolarization is coming from different foci, how do those P waves appear? Different. If you have the same foci that is causing the depolarization that go down to the ventricles, your P waves are coming from the same place, they're going to look the same. If you have different foci that are firing, you're going to have different forms of the P wave. The P wave for multifocal atrial tachycardia is going to be visible. You're going to see a P wave, but when you look from this P wave to this P wave to this P wave, you're like, why are all these P waves different? And specifically for multifocal atrial tachycardia, 3 or more different appearing P waves. 3 or more different appearing P waves. Tells you, especially in the setting of someone that has underlying lung disease, not cardiac. I mean, they probably do, but I'm telling you, on the exam, I'm going to give you a person that has severe COPD, they have bad pneumonia, they have some lung disease, and it's going to be an irregular tachycardic rate on your EKG, and I'm going to ask you what it is. You're going to see the P waves. So if I tell you lung disease, I want you to focus on multifocal. Because in real life, guess what? That's their underlying problem. And if you fix, they come in, they've got a severe COPD exacerbation. You fix the COPD exacerbation, they're going to go back into a normal looking EKG. The underlying issue is they're having an acute exacerbation, oftentimes leading to decrease in oxygen levels as well. And this is how it's causing irritability of the atria. And that irritability of the atria is causing multifocal depolarizations to occur. This is a narrow complex. This is a tachycardic rate. It is totally irregular, but we can see a P wave here. We can see a P wave here. We can see a P wave here. That one you couldn't really tell. Say a P wave here. Right, so you see these different P waves. There's an inverted P wave here. This is an obvious, this P wave is directly associated with that QRS complex. But what we're seeing, some of these, you may notice you can't see a clear P wave. But when we think about atrial fibrillation, we really can't see any clear P waves. Atrial flutter, we see flutter waves. This, we'll see the P waves. We will see the P waves, but they all look different. And again, sometimes you won't see them. Does everybody kind of look at that and see, yes, there's a P wave here, P wave here. What about this inverted P wave? Still a P wave, it's just inverted. It's going down, going. That's unusual, but we've got an unusual process that's occurring in the heart as well. So we have these 3 or more different P waves that are occurring in the setting of underlying lung disease. Atrial flutter, variable block, we've already talked about this. This is an example of atrial flutter with a variable block. Mechanism and pathophysiology that's underlying a flutter is the exact same whether it's variable or non-variable block. The presentation will be different because this is going to be narrow complex, irregular. Narrow complex, irregular. We have a 2-to-1 block here. We've got a 4-1, 1, 2, 3, 4-to-1 block here, 2-to-1 block here, 3-to-1 here, 1, 2, 3, 3-1, 2. So that's what causes the irregularity when you're looking from the R to R to R. But we still have those, what the appearance of those flutter waves. U, here's U, here's U, U, the appearance of those flutter waves. This is an example as well of atrial flutter with a variable block. Look up here in V1, we've got these flutter waves in V1. And we've got flutter waves here in lead 3. Come here, flutter, flutter. We don't really see very good R waves here. We have flutter and flutter here as well, flutter, flutter, flutter here. In a setting that is a person that has underlying cardiac disease. All right, let's take a break.
Whatever happens. I'm cool with it, whatever.
Right there.
What is she? Hopefully she'll stay it's only decided really,
Oh, yeah, it's like, studying how long good for you, trying to take a break.
I just cracked my man. Yeah, you hard in the pace. I gotta walk to get my body. Listen, he won this week. That's what. Downstairs. But it goes right here, not right here, somewhere right here. That's what I'm bigger up here. I'm smaller here, bigger. I got the beard. Trying to see if anybody had this back there. My belt says, barely make it. Yeah, like we're not waiting, we're doing it now. Oh, you have to.
So you see 800 pounds, as long as you're good, and if your legs are like open potted, walk around like this, next, you'd be good to go. Look at me, bro.
Big ass.
But we're healthy, you know, like all of the rest of us, we got a beard going. That's what I am. I do it.
Just right before.
Obviously, that's healthy. These are men that are doing so.
We're gonna talk about start with me.
You are Goggins. Alex Goggins. Over there.
See, you are. I can see it.
Yeah.
Oh, car.
No, not so bad. Could be worse. Practice is long, but so regular, right? For the first regular session, regular, do it our way. And our way is one happens the
Hey,
same.
throw your trash out, get the trash bag that's out of the can, take it out.
August, sir.
Like lengthwise.
Yeah.
Like P wave this way. Right?
Yeah. And then in between is the second regular. Yeah, R. And those waves are
Regular, P wave to regular, regular distance, and then irregular, they fluctuate, right? That pilot is
So when we're talking about regular waves, is when we're talking about investigation. In general, are waves that are regular or irregular? After that, you're looking to see why are they. What's your forecast? You have regular, irregular, narrow, and you have regular and irregular wide. So that's my brain time right now. So if you're giving points, like low points, low it is.
but that's specifically R.
My brain is so accurate. So you get not always look in the little up and down, but
Which word also
whatever you have, and you have wider.
First one, took out P or not. Took out the R wave. It's not consistent. It's irregular. Stuff in between. That is not consistent.
Until I take like 4 or 5 tests, kind of start because golfing more, so that's gonna be.
So the stuff, you're not gonna really tell you what golfing is. Not very good, but that's more telling than what you're doing. Wait,
You know how many times I've heard you say that? I'm never drinking again. So that freshman semester was like trash multiple times. No, but like freshman semester versus this.
Before we don't copy each other, you're gonna copy each other.
What's the second?
So, like I said, you're initially going to look at are they so like I said, narrow or regular? So regular, it just
That's what I'm saying though.
the point is
I was talking to them. I was like, so I left your house last night. And they were like, why don't you just
the narrow
I
wide.
was like,
So now we know
joke about that, but this semester I will. That's when we're making those accounts. Like me, Casey, and Lucas are gonna be like,
it's gonna be okay. This one is starting a lot. One of these, and that's the in between stuff. So like, is there a P wave? No, I didn't see any P wave.
So,
Well, so I guess we can blame Great Britain for tax. In 1799, this guy William Pitt the Younger, because there was William Pitt the Elder. So I guess back then they was junior and senior. So William Pitt the Younger thought it was a great idea, but really it was to support some war that they were having. Napoleonic War or something, so. But the bottom line is, we don't like it, because now we have income tax. Watch your head. All right, 1967, anybody know who that? Anybody? Anyone say? No? No? Boo! I mean, God, so forceful about it. Well, in 1967, they officially became the New Orleans Saints. And then, the day that changed our lives forever, in 2007, iPhone came out. And I'm kind of a plus sign. Like, I totally have a phone, but I totally feel like I would do great without a phone. I don't think I need a phone. I mean, I contemplate if I do or not. And then I'm laying in bed, like, having my phone, I'm like, oh, where's my phone? Maybe I would do something. And here's the last thing. Now, I have full confidence in all of you that you're going to make it through junior and senior semester, get on to phase 2, be so successful. But in the event that you either don't or you choose not to continue being a PA for the rest of your life, you could get $1 million. There's $1 million reward offered to any one of you that can decipher this script. Ancient Indus civilization script, $1 million buckaroos.
That's how you feel.
Right? So I'm like, you look like a zebra, and he's part of the where's my food? Like, I don't know, you know. So, but it's out there still, $1 million is out there. Maybe y'all wanna try it? I mean, that's pretty easy just to decipher something, like, I don't know.
How is
I mean,
AI
Chat
not figuring
GPT, decipher this. Chat GPT by $1 million risk. Alright. So tachycardia, narrow and regular, narrow and irregular. Put those together, the narrow and regular, the narrow and irregular. Put those things together. Now we're looking at the QRS complex. We know it's tachycardic, and we say, oh, greater than 3 boxes. 3 boxes is great. Wide complex. Wide and regular, we got VTAC, we have V flutter, and then anything that has what we call aberrancy or aberrancy. Okay? Anything. Aberrancy means a block, a bundle branch block. And we will talk specifically about bundle branch block. But anytime you have any rhythm, and you have a bundle branch block, you're going to have a wide QRS. Okay, so SVT, and I put this in there specifically because we just talked about SVT. We talked about SVT as narrow, and I want you to, in your mind, say SVT is narrow, SVT is narrow, SVT is narrow. Okay, I'm going to bring something up to you in a few minutes that you'll understand why. Okay? But VTAC, V flutter, okay, and then anything that has a bundle branch block. Ventricular tachycardia. 150 to 250 is our heart rate. Ventricular rate. Ventricular rate. So that's a fast ventricular rate. These patients are probably going to have some palpitations. Oftentimes, the atria are depolarizing, okay, but we don't really see the P wave because the QRS is so wide and so ugly because the ventricles have really taken over the pacemaking responsibility. And so we'll have these fast rates, and we're going to have this wide, ugly tachycardia. We have our QRS complex here. Now, some people are like, well, is this the R or is this the R? If you are taking time to figure that out, it does not matter. Because these patients need help. But really, this is your R wave up here, and then you come down to your S, R, S. Okay? But it really doesn't matter. And sometimes, especially when we talk about multifocal VTAC, you'll see like they twist. Sometimes it's R's up here and R's, sometimes it's R down here. Lots of things that can cause VTAC, and usually it's someone who has underlying cardiac disease. They've had an MI, they have ischemia, heart failure. Anything that can cause low oxygen can also push these patients into ventricular tachycardia. If they have valvular disease, ventricular hypertrophy, where the muscle part of the ventricle is really thickened, that can also cause VTAC. This is what VTAC looks like. Just big, wide, you can't tell, I mean, you can't really tell much. You can tell that it doesn't look like, we have an atrial right here. We don't even see a P wave in here. Actually, I can point out a couple P waves here, but it doesn't really matter. Right? But this is a P wave here. This is a P wave. It's a P wave down here. But it doesn't matter because when we look at this, we just see this really ugly, wide, complex, fast rate. So if you count this rate, count it from these R waves up here, that is super fast. So 300 is here, 150. We're about 150 or so. 300, 150 or so. So pretty quick rate. Are these guys talking to you? Probably. Very, very well could be. Very well could be. I had a patient not long ago that was sent to us from Lackland. He comes in, he's like, I don't know, maybe mid to late 50s, I think. Talking to me, saying what's going on. Oh, I was feeling a little weak, a little dizzy, had some palpitations. And my nurse, we put him on the monitor, and heart rate's normal, and then all of a sudden the heart rate looks like this. And the monitor looks like this. The nurse, Sue, you see that? I'm like, I have 2 eyes too. I can see it. How about you go get him some medication and we can treat this, no problem, right? Okay. But this is one that they certainly can be talking to you. Now, they may have syncopies, okay? They may have signs and symptoms, especially if they're going in and out of VTAC. But this is not the sudden cardiac death rhythm. VTAC is not that. There's a lot of people that go in and out of VTAC, whether it's sustained or non-sustained is kind of the key. Sustained is greater than 6 beats, non-sustained is less, or 30 days, sometimes it'll go 30 seconds, less than 30 seconds, greater than 30 seconds. So that's VTAC. Now, this is V-flutter. V-flutter. V-flutter is an extreme form of VTAC. Extreme form of VTAC, meaning if you were to look at this right here, does everybody see the difference between this rate and this rate? What do we have here? We have, like I said, we have about 150 here, but look at this. Every single black line has an R wave. Every single black line has an R wave. There's one focus in those ventricles that is just constantly going off, non-stop, because of irritability. Irritability in those ventricles. This, or these patients, if they are not unresponsive, they will be very, very quickly. This is a sudden cardiac death. This is, I felt lightheaded, dizzy, I passed out, and I died. We might get lucky, and there's bystanders around, and they saw someone go down, and they started CPR, or there was an AED. We might, but if there's not somebody there within a couple of minutes or so, this is not sustainable. No one can sustain a ventricular rate. What is this ventricular rate? What do we see here? 300. 300. That's fast. No one can sustain that for very long. They don't have enough circulating volume, right? Because the ventricles are being so fast that they're not allowing time for the ventricles even to fill and get a good push of blood out to the body. You get just little spurts of blood that's coming out because the ventricles are moving so quickly. Right, so MI, cardiomyopathy can cause this, drugs, cocaine. I tell people, like, I don't do drugs. I'm not interested in doing drugs. But if you do drugs, I said you do. If you do drugs, don't do cocaine. Cocaine's bad for the heart. Heart can't withstand cocaine. So do something else. I mean, I don't know about meth. Meth's pretty addictive. Heroin, maybe, I don't know. I'm not really sure, but don't do cocaine because cocaine truly does affect the heart. Heroin, you might be able to take. Cocaine, you're going to die because you have a big heart attack. Choose your drugs wisely. When we compare, I know. When we compare these two, plus I added one at the bottom, VTAC, V-flutter, and then that SVT with a bundle branch block, where SVT, we call it now SVT with aberrancy. That's what they call it now. Those are the words they use now. SVT with aberrancy. VTAC, V-flutter. The difference between these, if I give you a scenario and someone's talking to you, it's not going to be V-flutter. Not. If I give you a scenario and someone's unresponsive, could be V-flutter. You also need to see that this rate is much faster than this rate. Much faster, twice as fast typically, because this is a extreme form of VT or faster form of VT. Now, this SVT with aberrancy, we can see that this QRS is right on the verge of wide. Certainly not as wide as VTAC, not as wide as V-flutter, but it's right on the verge. So it's still considered a wide complex because of the aberrancy. You don't really need to know the difference between these three. I mean, you do need to know V-flutter and VTAC, but you don't need to figure out, is this SVT with aberrancy? Is this VTAC? What is this? Because guess what? The treatment is the same. And Dr. DeBoer, when he teaches you cardiology, he's going to talk to you about the treatment. I don't want you to focus on treatments in EKG because it's hard enough for us to learn EKG, let alone add the treatments. Well, I need you to see the rhythm and recognize these rhythms. All right, so he'll talk to you about the different treatments. But because it is sometimes very difficult to tell the difference between VTAC, V-flutter, SVT, The ACLS algorithm says the treatment is going to be the same initially, and then once we figure out how much we go. Now, SBT with aberrancy, this is what we're talking about. We've got the SBT, we've got that widened QRS. Okay, we can see a little wide QRS, little bit here, but that wide QRS in the setting of a regular R to R, and usually this is associated with a bundle branch block. So that's wide and regular. Focus on VTAC, V flutter. VTAC, V flutter. V flutter is an extreme form of VTAC, super fast. Unresponsive, VTAC, I'll continue at least for a little while. Now, wide and irregular ventricular fibrillation, polymorphic VTAC, and something called torsade. So ventricular fibrillation, very much like we talked about with atrial fibrillation, there's multiple foci in the ventricles that are firing simultaneously. They're all trying to take ownership of becoming the SA node. They want to be the primary pacemaker of the heart. And so they're fighting with each other, and each one of them is sending out a signal. And so we're getting some depolarization, but look at how erratic this rhythm looks. You might say, okay, well, yeah, I can kind of see an R wave here. I can see an R wave here. I don't know if this is a P, if it's an R, if it's a Q. It's so erratic that you can't often pick out any of the waves and the waves, the ST segments, the J point. You can't pick out much of anything on there. Again, this is one of those things where these patients are typically unresponsive, okay, or they've fallen down, and it's going to be fatal within minutes if we don't get this. Is a sudden cardiac death, usually due to some sort of myocardial infarction. Certainly, electrolyte reducer can do this. Potassium can do all sorts of stuff to the heart. Drugs, go back to cocaine again. And another time I have seen this is electrical shock. Right? So think about lightning strike. Lightning strike can cause VFib. And if these guys don't get immediate electricity, they're probably not going to do well. When you look at the ECG, and guess what? It's really hard to find ECGs of VFib. Why? Because we're busy saving the person's life. We don't have time for an EKG. We're not like, oh, let me get an EKG. Like, oh, the person's dead. Because when we feel the pulse, we're like, oh, there's no pulse. Let's figure this out. But if we're lucky enough to get an ECG, you may notice that it changes over time. This is what we call coarse VFib. So we see more deflection up and above and below the baseline. As time goes on, 30 seconds or less, we're going to go from this coarse VFib to this fine VFib. And then we have fine VFib down here, just before. Okay. So if we can catch them at the coarse VFib, we got a tiny bit of time to help them out. If we're already on this fine VFib, we'll be almost run completely out of time. So greater than 3 millimeters, we say, is coarse, and then less than 3 millimeters. This is an EKG of VFib. So in this VFib, we can see what it looks like to be maybe a couple of beats of VTAC in here. But what we'll see is those fibrillation, the fibrillatory waves in between what we might think is R waves, but we don't really see a lot of clear. Over here, I would agree with any of you that said, well, that looks definitely like, would you say it looks like VTAC, or would you say it looks like V-flutter? This up here. We have something on a dark line here and something on a dark line here. Well, that's pretty fast. That'd be V-flutter. VTAC is you're going to have a little bit of space in between those dark lines, right? So you can have that, but this patient is probably coarse VFib and soon to be fine VFib. Unresponsive, they need intervention quickly. That brings us to a really important point, a something called absolute and relative refractory period. The absolute refractory period, there is a time where it doesn't matter what type of insult occurs to the heart, we cannot cause depolarization to occur again immediately. And that is called the absolute refractory period. The absolute refractory period begins at the beginning of the Q wave, and it ends as we go through that upslope of our T wave, okay, where it's slow upgoing, and then it goes down quickly. It ends at that period where we start to go down with our T wave. So on the upslope is absolute refractory period. Doesn't matter how hard what type of insult occurs to the heart, it's depolarizing and you can't, it's repolarize, it's in that repolarization, and you can't cause another depolarization to occur. It is not the same if we talk about relative refractory period. The relative refractory period is at the end portion of that repolarization. And in the end portion of that repolarization, if you had an insult strong enough, it could cause these patients to prematurely go back into depolarization. And the problem with that is this, is something called R on T phenomenon. If you have somebody that has, most commonly for us, it's going to be something called a premature ventricular contraction, meaning the ventricles, for some reason why, we started off normal. We had the SA node that fired, it went on down to the AV node, went on down to the ventricles, started off normal. No problem, no problem. But then we had some foci in the ventricle that wanted to be a hero and said, I want to take over pacemaking responsibility. I'm going to pacemake. And it does that at the end of that T wave, the downslope of that T wave. And if that occurs, they can push these patients into this kind of this VTAC, or what we call it can push them into a VTAC, but it can also push them into a torsades. So it could be a fatal arrhythmia if their body's not able to pull them out of it. A couple years ago, there was a football player. He played for it. Bills? Yeah. Damar Hamlin, right? Yeah. Damar, whatever. Some Hamlin. Hamlin's name. Bills. He got hit like that during a play, right? Got hit in the chest. He got hit in this relative refractory period. And that insult to the heart pushed him into a fatal arrhythmia. But he was in a position that people ran onto the field immediately and provided medical intervention, and they were able to bring him down. That could not have happened if he would have been a millimeter of a second hit earlier, a millimeter of a second. Right? He happened to be hit on the exact time of that relative refractory period, that tiny downslope of the T wave, which caused him to go into this potentially fatal arrhythmia, but he had medical care. Okay? And so it's up for us, if we're not getting hit in the chest frequently, premature ventricular contractions. Premature ventricular contractions is though when the ventricles contract, we know it. And when you have a PVC, that is a hard enough insult to the heart that it can push these patients into this R on T phenomenon, where you are getting early depolarization, and that early depolarization then takes over, and it does not account for a normal depolarization. It pushes these patients into this abnormal electrical activity. One of the things it can cause is polymorphic VTAC. It can cause polymorphic VTAC, or polymorphic VTAC can occur on its own. And polymorphic VTAC is where we have twisting of the R wave. Where sometimes the R wave's up here, sometimes the R wave is down here. Sometimes it's up, sometimes it's down here. Okay, so it twists, right? And the rate for this is really high, okay, in the 250 to 300 or so. The issue is that this can degenerate into something like ventricular fibrillation, so VFib, which is a fatal arrhythmia if not doesn't have immediate intervention. How do we differentiate this from ventricular fibrillation? Well, when we talk about ventricular fibrillation, well, remember, ventricular fibrillation is just below the baseline, just a little bit, even if you have course, okay? And we don't really have any clear waves oftentimes with VFib. Well, here we can definitely see that this looks more like a, we have some R waves in here. We don't really see many P waves or T waves, but we definitely see some R waves in here. This is an R wave, this is an R, this is an R. But it's just twisting on where there are, if the R is up or if the R is down. People that have myocardial infarctions, myocardial ischemia, underlying cardiac disease can go in and out of polymorphic VTAC. Also something called Brugada, and we'll talk about Brugada, or even hypertrophic cardiomyopathy, where the heart itself is enlarged, can cause this electrical conduction abnormality and cause something like polymorphic VTAC. That R-on-T phenomenon, more commonly, causes something called torsades. Torsade de pointe, pretty fast heart rate, okay, can be caused from R-on-T, can be caused by prolonged QT syndrome, or if we give somebody 2 QT prolonging medications and they don't know they have an underlying prolonged QT, we can push them into a torsade. Okay, so oftentimes we can do this to our patients by giving them those medications. We have to be very careful. Low potassium can cause this. So if we have low potassium, what other electrolyte typically goes hand in hand with potassium? Mag, low potassium. And these patients might present with dizziness, they might have syncopized. Sometimes they'll be going in and out of torsade. A lot of times the body actually can, when they syncopize, the body is able to reset and then pushes them back in. So even if they come in, they feel fine now, if they have a history of syncope or pre-syncope or dizziness, it's good to get an ECG on them to see what is going on. Do I see anything? And we differentiate this because this is considered, people say it looks like you're twisting a ribbon, where it goes low amplitude, then taller amplitude. Shorter amplitude, taller amplitude. Shorter amplitude, taller. If you were to just look at this, it looks probably more like a ventricular tachycardia or flutter. Flutter is too fast, but the amplitude is changing. The amplitude. You've got a low amplitude here, a high amplitude here, a low amplitude, a high amplitude. That's unusual. You're not going to see that in flutter. Flutter is going to be consistent. It's regular. It's a wide complex regular. This is going to be irregular as far as we see that decrease and increase in our amplitude. This is an example of someone that started off looking all right, kind of. Okay, there's probably a couple things we can figure out in here, but in general, they say we'll do it. What you can see, this is probably from actually hypokalemia, pretty an inverted T wave. But they had an insult that occurred at the dominant portion of that T wave, and it pushed them into the torsade. That relative refractory period. We compare polymorphic VTAC versus torsade. Polymorphic VTAC is kind of all over the place, up and down. There's really no rhyme or reason. Okay, and our torsade is we have that increase in amplitude, decrease in amplitude, increase and decrease in amplitude. All right, fact or fiction? Do both. Lucas. Yeah. Okay, sir. What do you think? Apple a day keeps the doctor away? Is that some BS?
True.
True. How do you know that though?
That's what my papa told me.
Oh, yeah. Randy Ma, all can tell you, right? The truth is, there was a big study done by Ohio State University. Oh my gosh, right? Big study. I mean, they had thousands of people. And they had them eat an apple a day for, I think it was 1 month, for about a month. 4 weeks, they had to eat an apple a day. At the end of that 4 weeks, they checked their LDL, and guess what? LDL was better. What else do the apples have in it? Antioxidants. They had decreased inflammation in their joints, they felt better just on 1 apple a day. I don't think they said what apple it was though, so I don't know. Granny Smith apple, red apple, Macintosh apple. What about this nonsense? Langley. Sarah Langley, what do you think? Where you at? Okay, ma'am, what do you think? Going outside with your hair wet will make you sick. You don't think so? You look sick. Well, I'll tell you, my mom said it must be true. That's not even true. And I told her so behind her back, right? Totally didn't say that to her face. But here's the deal, the flu virus loves the cold. It exists in the cold. It doesn't like the heat, so it dies more in the heat. Right? So we don't get sick because we go outside with our hair wet. We get sick because we go outside and the person before us coughed and put the flu virus in the air, and then we walked right into it. Okay? So it has nothing to do with your hair wet. But you didn't hear it from me. So Grandma says it's the truth. Yes, ma'am. Yes, ma'am. That's all we do. North, south, north, south. Okay. Volcaba. Volcaba? Is that how you say it? Volcaba. Okay. Oh, yeah. Okay, sir. What you think's going on here? Here's what I want you to tell me. What is this rhythm? Narrow and irregular. So what are my differentials? Narrow and irregular.
Well, they're regular R wave and then P wave.
Yes, but what are my possible diagnoses? What are the things that we talked about that can cause narrow and irregular?
MAT.
Multifocal tachycardia.
You have your fake flutter with variable.
A-flutter with variable, and most common cardiac arrhythmia in the world? AFib. What is it?
That has 3 different P waves.
What is it?
Multifocal
Multifocal atrial tachycardia. Look at these P waves. Look at these P waves. These P waves are crazy. Okay, so we've got P waves all over the place. We've got a P wave here, and a P wave here, and a P wave here, here, and that's inverted P wave. They're all different. Some look the same, but you have definition-wise 3 or more different P wave morphologies in multifocal atrial tachycardia. How might this patient present? Short of breath, COPD exacerbation. It's a pulmonary problem that's causing this to occur. All right. Valdez, Kyle. Okay, sir. What do we have here? Not the diagnosis yet. Tell me what your rhythm looks like. Regular, irregular, wide, narrow, and then we'll go to diagnosis. That's the diagnosis. So don't say that. Okay, so is it regular or irregular? Regular, wide or narrow? Wide, the opposite of narrow. Okay, so regular, wide, radial tachycardia. So what are our differentials for regular wide? VTAC. You already said that. What more? What else? V-flutter. Anything else? Technically, that's what I want you to remember, right? VTAC, V-flutter. How do you know it's VTAC and not V-flutter? Rate. Rate. You know it's V-tac and not V-flutter because of the rate. V-flutter is still going to be regular, still going to be wide, but it's going to be boom, 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 boom. Okay, and probably the person's going to be unresponsive. They're probably going to be unresponsive. You run into the room, they're unresponsive. You got really fast rate. Wide, regular, V-flutter. You want in the room, your patient's like, oh, I don't feel so good. But if they're talking to you, probably going to be V-tac, right? All right, what about Collins? Okay, sir, so same thing, we're gonna go, is it, we know it's fast, is it regular or irregular? Wide or narrow? Narrow. So irregular and narrow, what are our differentials? There is. Multifocal equation. Multifocal equation. What is this?
That one is
Atrial fibrillation. Why? How do you know?
because there are multiple between the QRS complex
Yeah, so we don't have anything that makes sense very much really in between the QRS complexes. Okay? In atrial fibrillation, you're gonna see it. You're gonna see it in active people, National Guard Reserve people, you see it in other people, like you guys are gonna see it. It is a pattern recognition. Okay, and once you see it a couple times, like, you're gonna see so many normals, but when you see an abnormal, you're like, ooh, wait, I know that's not normal. And now I gotta remember what the differentials are. So atrial fibrillation, alrighty, what about Zachariah Frazier?
Dr. Love.
What you think? So wide or narrow, regular, irregular?
Narrow complex, regular,
Narrow, irregular? No, I mean, sorry, narrow, regular? Irregular? So you would say what? A flutter with a variable block, right? So again, let's look up at V1, let's look at 2, let's look at 3 and ABF. And look for those flutter waves. Look for those flutter waves. The difference between this and your atrial fibrillation is atrial fibrillation, I want you to think about the area between your R waves is typically very low voltage, very low voltage. They don't usually come up like you're going to see with atrial flutter. And truth be told, in real life, sometimes, in real life, not on the test, but sometimes you can't tell the difference. Sometimes you're like, oh, gosh, is that atrial? Is that AFib? And so I try to slow it down. And I look at their underlying cardiac disease. Okay? So sometimes, even people that have seen thousands of EKG, even us, we'll sit around the desk and be like, what do you think? What do you think? What do you think? You know, the treatment isn't much different as long as they're stable, right? But sometimes, but on the exam, you probably see something very similar to this. If it's flutter, it's going to be obvious flutter waves. Okay, let's see here. Oh, we are done. Yay. All righty, have a good weekend.